I much with myself, I do connection.
Good afternoon, everybody. Assalamu alaikum. Thank you for joining us for this webinar series. So I'm very happy to introduce you to this 5-part CPD webinar series that's being hosted by Qatar University Health. I'm Dr. Zakaria Nazar. I'm the CPD coordinator here at Qatar University. So this webinar series is focusing on autism spectrum disorder. The title of this webinar series is Navigating Autism Spectrum, a comprehensive journey toward compassionate and holistic care. And I'm very happy to tell you that we've collaborated with experts here in Qatar to really have like a multi-stakeholder, multidisciplinary approach to this webinar series. And from the outset, I just want to give a big thanks to all of the contributors who've helped in putting this program together. So what we have today, this is the first of a 5-part webinar series, and this will be delivered every week for the next 5 weeks on a Wednesday, and it will be a one-hour session. And usually they'll be run from 12 p.m. to 1 p.m. with the exception of next week. So next week the webinar will be from 1 p.m. to 2 p.m. So today's webinar, we're focusing on the presentation, diagnosis, screening, and genetics. And we have our speakers from various institutes who will introduce in a few minutes. The format of today's presentation and the subsequent CPD sessions is that there will be short presentations from our speakers. The presentations will last 5 to 6 minutes. We'll be collecting your questions from the Q&A throughout, and then in between the presentations, we'll be putting your questions to the speakers. So we're highly encouraging your interaction during this webinar series. We really want to get to understand your insights, your experiences with care for patients with autism. So please do contribute your questions to the Q&A. Regarding the CPD points, so at the end of each webinar, we will be sharing with you an evaluation. It's necessary that you complete the evaluation, including your Qatari ID and your license number, as well as your name. And we will then collate your responses and submit the attendance report to DHP within 48 hours. So as I mentioned, today we've got the focus on presentation, diagnosis, screening, and genetics. We have experts joining us from Hamad Medical Corporation, Sidra Medicine, and HPKU. And before we start, I would just like to confirm that the presenting authors and the Scientific Planning Committee have no relations and no conflict of interest to disclose. And the learning objectives for today's webinar is to recognize the core features, signs and symptoms and risk factors of ASD across different ages, to identify common ASD screening and diagnostic tools, and to discuss the relationship between genetics and ASD. Joining me today is our moderator, Dr. Shahad Ali, and she will just be as Dr. Shahad Al Amin, and she will be I will introduce her now, and she can talk to you about how you can submit your questions during today's webinar. Dr. Shahad.
Thank you so much, Dr. Zakaria, for this introduction. Honestly, personally, I'm very excited for this session and for the whole series in general, not only because we have a range of topics from presentation to treatment to like building an inclusive community, But as you said, the fact that we have such an incredible set of speakers from across different organizations in the country is just amazing. And this is why that's your chance. If you have any question throughout the whole session, please do not hesitate to submit your questions through the question and answer tab. This is going to be through the app Slido, as you see here on the slide. If you're logged in from your computer, Doctor, if you could just move the slide, please. If you're logged in from your computer, it will be either in the bottom, so in the taskbar here, or if you press on apps, you'll see an active session. In the next slide, we can see that if you're logged in from your mobile phone, just press on the three dots and look for the app either under advanced or under options. We will be still having the chat open for interaction and feedback and discussions, but we will be monitoring the question and answer tab only for questions. Now that we've set the stage, I believe we can start with our first speaker, Dr. Ammar Abu Shaheen. Dr. Ammar, you may share your slide. Dr. Ammar is a consultant in development behavior pediatrics and a deputy head of Child Development Center in Al Maha Center, Al Bakra Hospital. Dr. Ammar, once you share your slide, the stage is yours. Thank you so much. We cannot hear you, Doctor. Dr. Ammar, maybe you can try unmuting your mic.
You heard my voice now?
Yes.
We can hear you, yes.
We can hear you now.
And my slide?
It's loading. Yes, we can see it.
So, good afternoon all. I'm Dr. Ammar. Thank you for inviting me to participate in this interesting CBD activity regarding the autism spectrum disorder. I will start. I will start this. I will start this activity by presenting the autism spectrum disorder, focusing on symptoms and core features of autism spectrum disorder. To start with, I have no relationship or conflict of interest to disclose. This is my highlight. I will go rapidly because the duration is limited a little bit. You know all that April is the month of autism acceptance in all over the world. It's the time to raise the concept, the awareness of autism in the community, to help these individuals to reach their full potential, helping them to achieve the optimal health care. If we start with autism, what is autism? You know, I think all autism spectrum disorder is a neurodevelopment disorder characterized by persistent deficits in social communication and social interaction, along with a specific behavior, restricted, repetitive, and avoidance of change of routine. Usually the symptoms are recognized during the second year of life. We can diagnose in the second to third year of age. Some cases is diagnosed earlier, others later in school age when the social demand exceed the minimal capacity of the child. It's a spectrum, and it's not autism, it's a spectrum. And the word of spectrum doesn't mean it's slight or mild, as some people think. It's meaning that it's a wide range of presentation two persons of autism spectrum. One may be gifted, super talented, and the other may be intellectual disabled. One autism spectrum may be fluent in 2 or 3 languages, very talkative. The other may be mute or non-verbal. So it's a spectrum, different presentation at every age. This very alarming chart about the increase of prevalence of autism all over the world. This is in USA, according to Center of Disease Control in USA. If you noticed, from 2000, the percentage was the rate 1 to 150, while in 2020 the rate is 1 in 36. It's exceeding the diabetes in children, it's exceeded the cancer, so it's very alarming and need collaboration to manage this increase in prevalence. It is identified in one girl beside 4 boys, so it's more in boys, as you noticed. Unfortunately, it's associated with intellectual disability in 1/3 of cases. The core features of autism are separated in 2 domains. The first one on the left is the impairment in social communication and interaction, the difficulty in nonverbal communication, impairment in maintaining friendship or make relation with others. The other side is the behavior of the child, which is restricted, repetitive, stereotyped in speech or movement, with special interest and some sensory issues, hypersensitive or hyposensitive to sensory stimuli. Till now, the real or exact cause of autism is still unknown, and it's puzzled the scientists all over the world. The genetic role is very important. That's why we detect a lot of genetic mutation in microarray in the genetic study. If there is any sibling in the family with the diagnosis of autism, the risk is more and high. The advanced age of parents, especially the father, also can play a role. The low birth weight, prematurity, the neonatal complication also can play a role. The toxins, medication also are accused to can contribute to autism in collaboration with the genetic issues. Now, if we go rapidly to the sign, most of these signs I will show in the video. So, but in general, the child doesn't respond to his name. The eye contact is limited. Does not aware of danger always. He has some sensory issues. He covers his ears with loud sound. He has some repetitive movement. He can walk on tiptoe. He play alone, isolated from other. He can cry without reason or laugh without reason. He is attached to some object. He has a specific routine. He is frustrated and tolerated to change the routine. He has inappropriate play, repetitive with no functional or pretend imaginative play. Now I will pass to 2 videos. The first one for non-verbal child, okay, with autism. Clapping hand, which is hallmark for autism spectrum. Lining toys obsessively. Lining everything, trains, bottles of water, limited eye contact with others, repetitive activities. The child can pass 1 hour, 2 hours with the same activity. Interest in spinning toys, games, pressing the hands, lining up, lining balls. Hearing, touching, smelling toys, visual sensitivity, eyes, no looking to camera like the other sister.
Thank Jacob.
Avoid eye contact
Jacob.
with mother or stranger. In its own word, the time, it's for repetitive behavior, repetitive movement, like running, grabbing plants, jumping, waiting. They don't touch or mingle with other kids and siblings.
As if not wanting to be near his sister. As you can see, nothing has changed.
Limited eye contact. Don't mingle with other kids. Interact with them. Speech delay, non-verbal, verbal speech or talk signs. Sensitive to loud sound, noises, party, birthdays. Now I will finish with another video in verbal child teenager. It's a cartoon video, but it is interesting, and I will finish with it.
Hey, Nancy. Hi, Lionel. And let me guess. Sean, nice to meet you. Hello? Bree, I think Sean is in the
Interested in
middle of his
lining the
artistic
trains,
process.
focusing
That's
in
fancy for the
details.
way he makes art. One must approach with grace. Excusez-moi, Sean. May I say bonjour, which is French for hello? I am très looking forward to us making art together and being friends.
But actually, when they invented the coal engine, most trains were painted black because of the dirty soot.
What? Guys, I should tell you, Sean does things a little different. I understand, Lionel. He's an artist, just like moi. Luckily, I'm practically an expert at making friends. Sean,
Look how
I
he is
adore the trains you're
precise,
setting up to
punctual.
paint. May I join you?
Avoid others.
This sandwich has crunchy peanut butter.
Is that a oui or a no?
This is crunchy peanut butter, but I eat smooth. Smooth!
Why is he yelling?
I don't know. It's just peanut butter. Sorry, Sean, but don't worry. We'll ask my mom to make you a new sandwich.
Smooth peanut butter.
Definitely, buddy. Promise.
I only eat smooth.
Hey,
So as you see, if the child is teenager talking, the tone, the intonation is different. The conversation and reciprocity is limited. His answers are out of the context, and he has a specific routine. He doesn't tolerate crunchy peanut butter. So this is some of feature in teenagers or in adolescents. So this is the references, and I am happy to answer your question at the end of the session, inshallah. Thank you so much.
Thank you so much, Dr. Ahmad, for this informative presentation. I think it's really important to reiterate how autism spectrum disorder is a spectrum, as you said, and it can appear very differently in each and every person. You mentioned through your presentation that there's a range of risk factors. They can be biological, genetic, or even environmental. Can you perhaps talk a bit about the environmental risk factors? We hear a lot of things, about vaccination, about smoking, about the health of the mother while pregnant. So perhaps can you talk a bit about that?
Yeah, in reality, the environmental causes can play a role, but it's not the essential. The essential cause is the genetic. My colleague will talk about the genetic. We doesn't think that the smoking or the TV exposure, the anxiety, depression of the mother during the pregnancy is the reason of the autism. It's mainly the toxins, the medication, the viral infection, the complication of hypoxia or other issues during pregnancy or delivery can play a role in autism spectrum disorder. Yes.
Thank you so much for answering this question. We have some other questions from the audience, which we will answer, inshallah, at the end of the session. Dr. Madiha is our next speaker. So while Dr. Madiha shares her slides, I will be introducing her. So Dr. Madiha Kamal, she's a senior attending at Sidra Medicine, an associate professor of pediatrics at Weill Cornell, Qatar, and a professor of pediatrics and clerkship director at Qatar University College of Medicine. Dr. Madiha, if you're ready, you can start your presentation.
Dr. Madiha, are you with us? Dr. Madiha, we're facing some issues with your audio. While we correct your audio, there has been some further questions, Dr. Ammar, from the audience. So if that's okay, can you take the questions now?
Yes, for sure.
So there is a question here around the overdiagnosis and the underdiagnosis. So the question is that there are arguments that autism is overdiagnosed, leading to unnecessary interventions and labeling of children. And there's also an argument that autism is underdiagnosed, particularly in certain populations like girls, minorities, and adults, which you touched on. Can you maybe discuss that point? Maybe elaborate a little bit further, please?
Yes, in reality, this is an issue regarding the overdiagnosis.
Yes, Dr. Ammar, sorry.
So usually there is a criteria, the DSM-5, the revision criteria. We use the criteria, and there is no overdiagnosis or underestimation or under diagnosis of the autism spectrum disorder. We understand that some families have a denial and are so defensive, but at the end, this is the role of this workshop, this activity, to increase the awareness about the autism, the problem of some families or some nurses, health sector personnel. Some people put in mind that the autism is only the severe cases that they heard before, the child with aggressive behavior, self-injurious behavior, that will, the child which is severe sensory to sounds, the child with intellectual disability. But as I mentioned in the presentation, it's a spectrum, and each case of autism are unique. Even the twins, the identical twins, sometimes mothers describe a different presentation in the first and in the other twins, but both are autistic. So the range of symptom is wide. The diagnosis here in Qatar is logic, depend on criteria, international criteria, DSM-5, applying some international tools. My colleague, Dr. Asuna, will talk about these tools, okay? And we try to diagnose the children in MDT clinic and not from the first visit of the child. So we give the chance, we collaborate with other subspecialties, speech therapist, occupational therapist to put the diagnosis. So I don't think that there is over-diagnosis of autism, but the awareness of autism, the screening that done in the healthy center in Qatar here at age of 18 months and 30 months is very important. It detects the cases early and refer to child developmental center services for diagnosis. Yes, thank you.
Thank you very much, Dr. Ammar. Dr. Shahad, have the audio issues been resolved?
Good afternoon, everybody. Thank you for inviting me to this presentation. Mashallah, Dr. Ammar did a great job in his presentation. He practically covered everything we need to talk about. And Shahad, if you don't mind, just move on to slide 4 and 5, because Dr. Ammar, mashallah, he covered everything already. I'm just going to re-emphasize on the autism is deficit in the social function, social communication. And slide 5, you can see the DSM-5 criteria, which I'm just going to repeat what Dr. Ammar had said: deficit in the social communication and social interaction. You need 3 of the 3, which is social emotional reciprocity, the verbal and the nonverbal communication, and relationships. Ability to make friends is something that normally we cannot capture in the young group. However, it's more obvious in the middle school and high school when they realize that they are not able to make friends. Especially in the higher functioning children, it can be confusing. In the lower functioning children, it's easier to detect even at early stages. Then we move on to the second group, which is repetitive behavior, so repetitive speech or movement. Excessive adherence to routine, restricted fixated interest, and sensory differences. You need 2 of the 4 to meet the criteria of ASD. So what I teach my resident and student is that one thing to make the diagnosis, but the whole different thing is to look at their cognitive abilities, because this is the first question that parents are going to ask you: will he be able to get enrolled in a normal stream school? So the next slide, it tells us the severity, and it has different levels of severities. And the slide after, it will talk about Shahid, next slide. So when we start managing, we target the behavior, the development, and the education. This is the main 3 things that we would like to achieve. And the goals of therapy, the next slide, Shahid, is to maximize the function of the child with ASD, to move him towards independence. A lot of the parents work really hard in the first few years to get him to that middle school where he is more independent independent, and that independence doesn't happen to every child, depending again on his cognitive abilities, and we would like to improve his quality of life. And next slide, it tells you how important is parent and family involvement, and the training of the parents and working closely with the parents are extremely important. A lot of parents don't know that their role is actually more important than any other therapist. And slide number 11, Shahad, will again tell you that parents can make a great job, and the communication, what I tell parents, the first thing you need to work on is really communicating with the child, whether depending on the child, verbal or nonverbal. Definitely you will have to find ways to communicate to reduce the anger. Children who cannot express their feelings, they do develop anger. If we move on to to slide number 13, we're gonna look at the ASD. Is interesting. Some don't get diagnosed early in life, and these are the higher functioning, and some aren't, and some do lose the diagnosis after great intervention from the parents. And my last slide I want to talk about is the really parents and teachers' role. And I would like to emphasize how our role is to accentuate positives. In every child with ISD, most children, they do have a lot of strength. Let's build on these strengths, reduce the weaknesses as much as we can. A lot of parents, they tend to work really hard, look for their weakness, and let's rectify that. I really recommend that work on building their confidence, building bricks on their own strength. Encourage communication as much as we can. Treat what you see. If they're hyperactive, we'll treat that. If they are impulsive, if they're angry, we're going to treat that with medication. Plus the therapy, and therapy, of course, speech and OT and everyone else. And in later life, they can develop anxiety and depression, and definitely we need to address that. Thank you very much. Happy to hear questions.
Many thanks, Dr. Madiha. There is one question that's come from the audience, and this is regarding the national screening. So this is something that Dr. Ammar, he touched on. He mentioned that there is some national screening within Qatar that maybe begins at 18 months. Are you able to elaborate on this, please?
Yeah, Dr. Ammar would know about it because he's the head of the Al-Wakra Hospital and Rumeila Hospital, and the national screening program that was established by the Child and Adolescent Strategy, it's done at all health centers, and with those patients that we detect red flags, the primary care physician refer these cases for early assessment and intervention at the Rumeila Hospital, and they do receive accurate referrals from the primary health care. Yeah.
Thank you. Dr. Shahad?
Thank you so much, Dr. Madiha, for this insightful and comprehensive presentation. We will be collecting other questions, inshallah, and answering them later as well. Right now, we can move to our next speaker, Dr. Sana. So, Dr. Sana, you can share your slides. Dr. Sana Tahtamouni is a consultant, developmental pediatrician, and clinical lead for early intervention services. She works at Hamad Medical Corporation, namely at Al Maha Center and Child Development Center. Dr. Sana, you may start your presentation. Thank you so much.
Thank you, Dr. Shahad, for the introduction, and thank you, Dr. Ammar and Dr. Madiha, for your presentation. I will be presenting the common ASD screening and diagnostic tools. I have no conflict of interest to disclose for my presentation, and I would like to start by highlighting the importance of early identification to achieve the goals that was mentioned by Dr. Madiha to improve the quality of life. That studies have shown that early intervention services can lead to improvement in communication, social skills, and adaptive behavior in children with ASD. And to be able to start the early intervention, we need to do accurate diagnosis and early diagnosis to allow timely access to intervention services. And screening also plays a crucial role in early identification to identify children that are at risk of ASD in early stage, enabling prompt referral for comprehensive evaluation and intervention, and doing the proper diagnostic and screening assessment will avoid the over and under as the diagnosis that was mentioned later. The first part of my presentation is the screening. Screening usually is the step done at primary care level to identify individuals with at risk of ASD and may require further evaluation. It is done by using ASD specific observational questionnaires and observational tools that are brief. It's recommended by the American Academy of Pediatrics that all children should be screened specifically for ASD during routine pediatric visits in primary care at 18 months and 24 months of age. Here in Qatar, the recommendation that was done by the national strategy is at 18 months and 30 months of age. Additional screening might be needed if the child is at risk of ASD, like a child with family history of ASD, or the child has behavioral symptoms that identified during the routine visit, vaccination visit, or the parents has concern about the ASD. In this case, additional screening is recommended, whatever the age of the child. The screening tools that are recommended for ASD, red flags that were mentioned by Dr. Madiha, and these are the tools used in Qatar. In the USA, the used screening tool, and it is a validated tool, is the modified checklist for autism in toddlers. The new version is the revised and follow-up version, MCHAT. It is designed for children between 16 and 30 months of age. It's answered by the caregiver. It's more specific than the previous tool, which is the MCHAT. And it is a two-stage screening tool. It's validated to be used in primary setting. And the other screening tool is the social communication questionnaire. This is a primary second stage screen in research, but still can be used for children who are above 4 years of age in primary care setting. There are other screening tools, like the screening tool for autism in toddler and young children, and autism spectrum quotient, but they are not used here in Qatar, so I will not go into details in these screening tools. The MCHAT is a 20 parent reported questionnaire, and it is yes and no question. Takes less than or around 5 minutes to administer and 2 minutes to score. It has high sensitivity and specificity. It's not used in Qatar because of, I think, the limited time in primary care visit during the visit to primary care. And this MCHAT has two screening stages, as I mentioned. In the first stage, it determines the risk category of the child. If the child scored between 0 and 2, the child will be classified as low risk when no further follow-up is needed. If the child scored between 3 and 7, will be classified as medium risk when a second stage screen is needed. And if it is above 2, the child needs referral to developmental pediatrician for assessment. And if the child scored between 8 and 20, it will be considered as high-risk child, and immediate referral should be done for further evaluation. The social questionnaire is a 40 parent reported question, yes and no question. It takes less than 10 minutes to administer and less than 5 minutes to score. It has high sensitivity but less specificity for the condition of ASD, but it's still highly recommended to be used in primary setting. In Qatar, the screening tool that it's used is the red flags. These red flags are used currently. It's a 14 questions, usually reported by parents. Again, yes and no question to target the main features of ASD that may appear as early as 12 to 24 months of age. It was done by collaboration between primary care and child development center. Implemented around 10 years ago to enhance the screening for ASD. No cutoff score is recommended. Usually, it depends on the clinical judgment of primary care physician to refer for further ASD evaluation and assessment. The second part of my presentation is the diagnosis, which is usually done at our center or developmental pediatric, etc. in Qatar. As any medical pediatric problem, we start by history taking, focusing on past medical history, neonatal history, and most importantly, the developmental history. We need to look in details on the core symptoms that was mentioned by my colleagues before, core features of autism, and we need to do physical examination, focusing on observation, looking for dysmorphic features, skin examination, and neurological examination. Usually, this step is done on the first visit to child developmental clinic. On the second visit, usually is the formal diagnosis, and it's a comprehensive assessment. An MDT clinic, usually there's a developmental pediatrician with speech therapist or psychologist. And in this visit, most of the time, the formal diagnosis is done. We need to look again for the core features of autism and to make sure about the presence of symptoms, impairment of speech, social communication. We need to observe the behavior. In this visit, we do caregiver interviews and direct observation, and we use standardized assessment tools to support our diagnosis. The most commonly used tools here in our center is the Diagnostic and Statistical Manual of Mental Disorder, the DSM-5 criteria. And the second tool is the Autism Diagnostic Observational Assessment tool. There are other tools but we don't use here because it's time consuming. And these tools which are used are considered the gold standard for diagnosis worldwide. The DSM-5 criteria was mentioned by Dr. Madiha before. We do caregiver interview and direct observation looking for the major criteria of ASD, which is the deficit in social communication and interaction. And we look for the presence of restricted, repetitive behavior, interest, or activity. To make the diagnosis, the symptoms must impair function and should be present in early developmental period and should not be explained better by another problem like intellectual disability or global developmental delay. If the child meets the criteria of DSM-5, usually the diagnosis can be done from the second visit. But if the child is still not clear, or the parents are not convinced, we are not convinced with the diagnosis, and it's a query case, we go to the second, more detailed assessment, which is Autism Diagnostic Observational Assessment. This depends on observation. It's a semi-structured behavioral observation of 4 modules. We choose the module based on child age and level of language. It can be done as early as 12 months of age, and it uses combination of standardized play activity, verbal interview. It takes around 40 to 60 minutes to administer, but additional time is needed to score. So in summary, autism diagnosis requires a collaborative approach by experienced practitioner, better in MDT setting, and we should use ASD-specific assessment to reach a specific diagnosis. Early identification through proper screening and early intervention leads to a better outcome. There are guidelines on the site of Ministry of Public Health that was done by the National Autism Strategy Team. It is available on the website. It covered the whole topic of autism, but the only problem that it's old now and it is under the process of update. Inshallah, it will be updated soon, but it's comprehensive guidelines. Only it needs to be updated. Thank you. I'm ready for questions.
Thank you so much, Dr. Sorry.
Do I need to mute? Because
I think the problem is on my side. Can you hear me well now?
Yes.
Thank you so much, Dr. Sana, for this comprehensive presentation, especially mentioning the different types of tools that we can use. Perhaps I want to take a step back a bit. If, let's say we have parents at home who have children and they would like to know when to actually look for a diagnosis. Is there any like specific sign or symptom that's very common, something to look out for that would tell them to actually go ask their primary caregiver or doctor for an assessment for ASD?
Yeah, the most important thing, in the first year of life, there is no much symptoms. It's mainly the eye tracking, the eye contact, the social smile, and it's not, there is no much symptoms. But you know, on discharge from a woman hospital, on discharge from NICU, usually they are giving a book with expected normal development. And on
Okay.
routine visit from the first vaccination visit, which is at 2 months, 4 months, 6 months, 9 months, there will be all the time developmental screening, not ASD
Yes.
specific, but there will be developmental screening. And the primary care physicians, they look into and you know, raise the awareness about possible ASD, and they look into these features, any deviation from normal development. And the main thing is the eye contact before 1 year of age. But you know, the developmental screening will be done on regular visits, and if there is any deviation from normal, parents should mention their concern.
Thank you so much.
Yeah, I don't know if I
Go
answered the
ahead.
question.
Yeah. There's actually one other quick question that we have from the audience.
Yeah.
1 second. Actually, perhaps for the sake of time, we can move on with the next presentation and then just compile all the other questions to the end, just to leave time for Dr. Khalid Fakhru's presentation. Dr. Khalid Fakhru is a Chief Research Officer at Sidra Medicine and Chair of the Precision Medicine Program. He also holds adjunct faculty appointments at both Weill Cornell Medicine and Hamad bin Khalifa University, where he teaches classes and mentors the next generation of master's and PhD students in human genetics and genomic medicine. Dr. Khalid Fakhru, welcome. And
thank you,
you
Shad.
may start your presentation.
Can you see my slides?
Yes, we can see it.
Okay, great. I'd like to start just by thanking the organizers, thanking Qatar University for this opportunity, Ministry of Public Health, and also thanking the previous speakers who really gave a wonderful picture of some of the clinical and features and traits of patients who live with ASD. What we're trying to build at Sidra has really been a systematic way of looking at how do we do rigorous research on par with some of the global powerhouses of ASD around the world. So I'll talk to you a little bit about that today. I have no relationships or conflicts of interest to disclose. Today I'll give a very quick outline of an introduction to Sidra Medicine for those who might not know us on the webinar. An introduction to my lab, which is the Laboratory of Genomic Medicine here. And then I'll talk about the Baraka study, which is our flagship autism study. And I'll cover some of the work that we've done and we've actually published so far on the genomics of autism, and how we're trying to use the data set to extract more value to make fundamental biological discoveries in autism. And then I'll summarize. So this is going to be a departure from the previous talks. It's going to be fairly scientific. If you're not into the science or want to doze off for a little while, it's okay. I completely understand. But if you're at least very curious about where the genetics of autism are today, and you'd like to see what we've been doing in Qatar, then I urge you to bear with me and please ask any questions that you might want to ask. So Sidra Medicine is a women and children's research hospital. We're built as an academic medical center, which means that we put equal focus on research and education as we do on patient care. Our vision is really to become a beacon of learning, discovery, and exceptional care, ranked with the top academic medical centers in the world. We have many different subspecialties here at Sidra. The vast majority of our patients are pediatric tertiary care. If you have a child with autism or you have a family member or a friend with autism, you probably at some point have come to Sidra. Most of what we do is related to genomics. We've sequenced over 40,000 genomes to date. Actually, that number is closer to 50 today. So we have a very strong strength in genomics. So in terms of areas of research, most of what we do is around pediatric rare and undiagnosed disorders. We also look at maternal fetal health because we do have a women's program here as well. And then we do a lot of population genetics, bioinformatics, and we're the national reference genome lab for the state of Qatar. So this is my lab. down on the bottom left, we're called the Laboratory of Genomic Medicine. And the way we look at what we do is basically when you think about traditional medicine, you think about the medicine of the different parts of the body. So, the brain or the heart or the kidneys. But if you go back to first principle, we know that all of these organs have arisen from a single cell. And that single cell basically contained the entire complement of all of the DNA that dictates how all these organs are going to develop, not just initially in childhood, but also over time. And so the principle we follow is that if you have this human genome, which is the instruction book of life, and you can read it, it's high resolution today, and it creates every single cell and every single organ in your body, then if we study it and we understand it, we can start predicting and treating disorders from their cause rather than their symptoms. And this is really what precision medicine is. It's the medicine of cause rather than the medicine of symptoms, which is what traditional medicine tends to work with. So the question we ask is what causes human disease? So human disease can be caused by many things. There's genes, environment, obviously, nutrition, lifestyle, infections sometimes cause disease, and so forth and so on. When we look at pediatric rare disorders, we're really looking at this top left quadrant of this figure, where it's mostly going to be nature, the genetic load, and less of it is going to be the environmental load. And the reason we think that is because these conditions happen in childhood. So if you think about cardiovascular disease, for example, it would be somewhere down here where there might be a genetic load, but years of potentially smoking or a bad diet or bad self-care could also cause disease. So pediatric rare disorders, there's thousands of pediatric rare disorders. Many of them are going to be caused by single genes, and many of these children suffer from something called a diagnostic odyssey, which takes a very, very long time to find their cause. So autism is no different. Autism is usually, the diagnosis of autism in the clinic is usually straightforward, but establishing a genetic diagnosis for autism is a much more complicated process, as you will see now. So the question that we were faced with is why is it important to study ASD in Qatar? And so if you look at large global efforts around ASD, you'll see these major efforts: Autism Speaks, AGRI, Spark, Safari. They all have thousands to tens of thousands of patients that they've already studied. And so through those studies, there's over 1,100 genes that have been found associated to ASD worldwide. And so there's many questions that come to mind. Are these the same genes in our population? Are they going to be different? And how do we know? And so if you look at the Middle East in comparison, there's very few studies. They're mostly fragmented studies. We know that in Qatar we have about 6,000 to 8,000 families that have at least one member with ASD. A recent prevalence studies shows that it's around 1 in 88 children have some form of autism or are on the spectrum in the country. And to be honest, when we looked at the literature back then, we only found a very small number of genes, maybe around 20, that had been identified in the GCC in families with autism. And so main questions that come to mind are these genes specific to our part of the world, or do we share any genetic architecture with global populations? And if so, how can the knowledge of genes help us with personalized treatment and intervention? And that really was the motivation for the Baraka study. You may have heard of the Baraka study, but the word Baraka was selected for its dual connotation. So in Arabic, we all know that the word Baraka means blessing. And that really is what we're studying when we study patients with autism. At the end of the day, every one of our children is a blessing from Allah. And then Baraka is also an acronym. It stands for Building a National Resource for the Advancement of Knowledge of Autism in Qatar. And so I'll talk a little bit about how we set up this study and some of the preliminary findings that we have. So the very high level, what we do is when patients want to enroll, we usually schedule an appointment for them. They come to the hospital, they consent for being enrolled in a research study, which is very different than a clinical care approach. With the research, we do a lot of different questionnaires that we administer to try to look at some of the environmental impact of autism. All of our questionnaires are benchmarked in collaboration with Sick Kids Hospital, which is a global leader in ASD research. We then collect and biobank samples from the patient, from the family members, from siblings, whether they're healthy or affected. we really want to try to build a big resource for autism. And then we usually do whole genome sequencing on these individuals. So we've actually started multiple enrollment sites. We enroll at CIDRA for multiple different clinics. We enroll at HMC. We also have collaborations with multiple centers inside the country. And as I said before, we collaborate with Sick Kids. And through Sick Kids, the entirety of our study is actually represented on the Autism Speaks Google Missing platform. So if you go to Missing, you'll see that it's true that they have 100,000, they have tens of thousands of patients now from around the world, and then you'll see a small cohort of 100 from Qatar. And really our goal is to grow that cohort as much as possible to give the Middle East larger representation there. So it starts by identifying families. This is usually done in the clinic. And then once the families are identified, we send them all for routine pathology. And so we rule out any families with known causes. So if the child has Fragile X or has a good microarray finding, those would usually not be enrolled for further research because the genetics are known. However, for all the other families, we enroll them into this research with very wide consent and a very detailed environmental questionnaire. And then, as I said, we do a biobank of all of their samples. The first pilot phase that we just published was on around 100 families. So this was 372 participants, because when we count the number of children with autism plus their parents and their siblings, the majority of them are simplex. Simplex means there's only one child that's affected, and then we had 2 families that had multiple kids who were affected with autism. As you'll see, the age of this is mostly going to be pediatric because CIDRA Medicine is a pediatric center, but we don't have any restriction above 18. And as we know from autism, the male to female ratio is 5:1, and this is consistent with global averages. So we also know that autism has many comorbidities. This is just a different way of looking at some of the comorbidities. I have them in tabular form here in the left. In the majority of our patients also have ADHD. Some have intellectual disabilities, some have speech delay, and some have other comorbidities. This on the right is just a different way of plotting this for a scientific audience, where we show the frequency of the different combinations of comorbidities in our cohort. We also look at the study demographics. The study is open to literally anyone. We do not have any selection criteria in terms of ethnicity or in terms of country of origin. Any patient with ASD can be enrolled. The vast majority, by chance, in the first 100 happen to be of Arab and South Asian ancestry. And as you'll see, there's relatively high levels of consanguinity. Consanguinity means that parents are usually related, and this is not surprising for our part of the world. We do see this not just in ASD, but across many different rare and undiagnosed disorders, etc. So as I said, over 85% of our families so far have been in MENA and South Asian population. So this is a one-shot look at everything that we do from a whole genome perspective. I don't expect anyone in the audience to fully understand this. It's a fairly technical slide. But the point I'm trying to make is that when we do whole genome sequencing, we are really doing comprehensive analysis of every single thing in your genome. And this is really state of the art. Most labs that send a sample for genetic testing will look at one or a few genes, or they might look at one or a few types of mutations. But really the pipelines that we've built at CIDRA over the last decade for genomic analysis have come in very handy when we look at autism, because autism is a very complex phenotype to study genetically. These are just some examples of families. There's families where you have, a single proband, and so we discovered mutation in this gene called STAG1. This gene is sitting in global databases, and it's known to cause syndromic ASD. It's also known to cause severe ASD with mental retardation. And as we know from our family, we do have intellectual disability and ASD present in this proband. This is a way of looking at it, at the genetic data. Also, you see that the mother and the father and the sibling, they don't have this red dot, and this red dot is really the mutation that's observed only so the proband really means the patient with the condition. And so there are articles on this STAG1 gene being involved in ASD. Here's another family where we actually have a father and 3 children who are all affected. And it turns out by looking at their genetics that they share this mutation in a gene called dynamin-1. And this gene is known to cause developmental delay and epileptic encephalopathy. And so we know a little bit about how this gene functions. And again, we see it shared by the proband, the father, and the two siblings, but not by the mother. And so this has also been published. We also see different types of mutations. So you might have heard of chromosomal microarrays. So chromosomal microarrays look at events, deletions, duplications, changes in the chromosome that are on the size of about 1 million bases or more. That's usually the resolution that you can look at with chromosomal microarrays. However, there's a lot of similar deletions and duplications that happen on a very small level. And here's a family where this child that has a very, very small deletion. It's only 2,000 bases. So it's only 2,000 letters out of billions, but only 2,000 have been deleted. And as you can see, the mother has only one copy of this deletion. The father has one copy, but this child happens to be homozygous. So you see this when you have consanguinity, which means the parents are related. That's how they both share this mutation in the first place. If they were not related, it would be very unlikely that they would have this mutation together. And then because they're related by chance, 1 in 4 of their children will be homozygous. And this is actually what we see in the proband. And so we see this deletion in EVOL2. And again, this is sitting in the Safari candidate with a very high score. In the interest of time, I'm just going to summarize our results real quick. So in 27 out of 100 families, we discover a genetic cause. So this is about 1 in 4 children have a clear genetic cause for autism. And most of the individuals that we had recessive autism. I'll show you this in a comparative shot. So on the right is the Baraka study. This is our study. The red are the patients that we did not diagnose. So 73%, 27% we found a genetic diagnosis in them. When you compare this to big cohorts like Missing and Simon Simplex cohort, you see that we have about a 2-fold higher increase in establishing a genetic diagnosis. And we think this is because of this slice of the pie. So in global databases, no one really has recessive autism. It's very rare for parents to be related in global databases. Whereas for us, we have a large percentage of our pie can be explained by recessive mutations. And so this is statistically significant. This is just a way of showing it scientifically, that we have a significant enrichment for recessive ASD in the Qatari cohort. And what this means is that recessive conditions are easier to predict and screen for, so we can screen for it premaritally or even in a newborn, and this can support with prevention and intervention. This paper has been published at the end of last year. As you can see, many people, including Dr. Madiha on this webinar, have contributed to the study, and we aim to publish more. So I just want to go back really quickly in the last few minutes to this idea of having a biobank and why it's important to have a biobank for ASD. So this is not a one and done. This is not something where we study it once and then that's it. If you're negative, you're negative. And if you're positive, you're positive. And then we give back results. This is really about thinking long term, about how if we grow the patient population cohort, what we can actually do for the ASD community. And so this biobank is really important because from these same samples that we collected at research consent, we can do a lot of other work. Metabolomics and proteomics is another type of work that we can do in autism. So metabolomics and proteomics are just fancy words of saying that we can look at all other small molecules that are not DNA, they're not genes, but they're small molecules that are circulating in your blood, and they can tell us about your biological state. So we can look at thousands of these all together in a very, very small 10 microliters of samples. Like you cannot even imagine how small it is. So 10 microliter is 1/100th of a milliliter. So when you take 5 ml of medication, think of 1/5 of that and then 100th of that. So that's how much blood we need to be able to get thousands of proteins and metabolites in the lab. And so this is one study where we looked at the metabolomics. We took from the Baraka cohort, because we have control siblings. That's why it's very important if you enroll your children to include both affected and unaffected, because they can really, really help with these types of studies. So we include cases and controls, and we look at, again, thousands of metabolites across their blood samples, and we discover metabolites that are what we call significantly dysregulated in individuals with autism. And as expected, these metabolites fall in pathways such as urea cycle, glutamate metabolism, arginine and proline metabolism, which are already known to be heavily involved in autism spectrum disorder. So it's good that we can find the things we expect to find in our blood samples. That means that our collection and our scientific approach is very sound. And this also means that as we grow our cohorts, we're going to start finding new things that no one else has found that are going to be specific to our cohort here in this part of the world. We also looked at the proteomics. So we combined our Baraka cohort with 2 other cohorts globally to become a large data set. And again, this work has found multiple protein modifications that are significantly enriched. So wherever you find a p-value that's less than 0.0001, you know that enrichment is highly significant in ASD versus typical development children. So these are normal development children. And so this has been replicated across 3 cohorts, and this is why it's important to create a biobank, because we can start contributing to global studies. And this has been replicated actually because our data set starts in very, very young age. We found that signal in the youngest age category. And this has also been published. This was work that was led by Qatar University. And again, this was because we had a biobank here and they applied for access. We gave them access to all the sample and they were able to actually run this project themselves completely independently. So this is why when I say that the Baraka Qatar study is really a groundbreaking achievement for this part of the world, is because we are really building a national resource. This is not just for Sidra to use. This is really for the scientific community to use. So I'll end there, and I'll just summarize with a few slides. One is that we all know that ASD is incredibly multifactorial, so it has contribution from genetics and from environment. Using state-of-the-art whole genome sequencing, we discovered genetic cause in about 1 in 4 children, which you might think is low, but it's still double as high as international averages. So that's actually relatively high right now. Many of what we discovered inside Qatar has been recessive. And again, this is not Qatari only. This is all the patients that we had. And so when you find recessive mutations, it helps with screening programs in the future. The benefit of biobanking and why we ask participants to biobank, it might not be obvious at the start, but it's really because these same samples can continue to give and give and give to the research community in ways that you might not imagine possible today. As technologies develop, there's going to be a lot of discoveries that will be made in the future, thanks to the biobanking that we do. And again, if we really want to have the right amount of power to discover new genes and new biomarkers and new treatments, we need to grow our cohorts. And we're now looking at pan-GCC efforts to try to get more patients from across the board enrolled in studies like this. So again, I just want to remind the audience that the Baraka is a growing national resource. If you want to contribute to it because you or a family member has autism, please feel free to enroll. If you want to access it as a researcher, please feel free to access it. And if you're a young student sitting in the audience that's thinking about an undergraduate project or a master's or a PhD project, and you're not really sure where you want to start, but you want to do it in autism, please get in touch. We would be happy to help you and to guide you and for you to use this data set. So I will stop there. Thank you very much.
Many thanks, Dr. Khalid. Very comprehensive presentation, and also thank you for the invitation for future collaborations in terms of research and practice. Thank you so much. Just one question relating to your presentation is around, so you've discussed around the excellent ongoing research into like biological markers and genetic factors. How far are we away from a definitive biological test for an autism diagnosis?
Oh, so a definitive biological test is going to be impossible, and it's because we saying something is a definitive biological test automatically assumes that this is homogeneous. So this is not let's say diabetes or obesity where there's going to be a lot of homogeneity. Autism by definition is a collection of rare conditions. And so you have thousands basically of different types of autism. That's why the prevalence is so high despite its severity. And so the way we tend to think is that we will have multiple biological tests that are going to be helpful for different types of autism. And so but it's going to require research to develop more of these. So for example, this recent study that was done, that was led by Qatar University by Dr. Naila there, looking at proteomics of autism, they found these glycation markers in as early as sub 5-year-old children, so in the 2 to 5-year-old age. And so that could be a study. That could be a biological marker in those kids. But again, only a small subset of those kids had those markers. And so that's the thing, is we cannot say definitive, but we can say that if we subset ASD, we'll be able to understand it better.
Many thanks, Dr. Khalid. So just in the interest of time, if it's okay with the panelists, if you can stay on the call, we will try to go through as many of the questions as we can. But just for those of participants who need to leave, the evaluation has been put in the chat and it appears on your screen now, so you can complete the evaluation. But in the meantime, myself and Dr. Shahed will be putting your questions to the speakers. Dr. Shahed, would you like to go first?
Thank you, Dr. Zak, and thank you so much, Dr. Khalid, for sharing your experience and your knowledge about this topic. This is such an interesting topic, and the Baraka study, as you said, it sounds like such a groundbreaking study. Actually, we have some questions from the audience. The first is directly related to the Baraka study. The audience is asking, how can they enroll in the study? Can you perhaps elaborate on that?
Yeah, so we have collaborations across multiple sites and hospitals in the country. I think the easiest would be to come to Sidra. We have Dr. Madiha is the leading physician on the Baraka study. We also have other physicians at Sidra in developmental pediatrics and psychiatry who are also involved, and so they usually evaluate the patients first. To make sure that they're eligible, and then they would call the research team to enroll patients into research.
Thank you so much. And there's actually another very interesting question from one of the audience member. You've spoken about the contribution of genetics to autism. One of the attendees is asking, is the influence of genes passed from the mother versus the father, can it be different, or does it not matter?
So yes, I think that's a very good question. So we know from global studies, okay, that most of autism is caused by de novo mutations. De novo mutations is just a fancy Greek word of saying that these mutations are not observed in either the father or the mother, if you'll believe it. So these are mutations that occur spontaneously in the germline, and they can either occur in the father's germline or the mother's germline and get passed on to a child. Okay, and these are spontaneous mutations. They happen across, there's about 70 of these that are introduced per generation, and they could affect genes causing autism or genes that do not cause autism. We don't know what they're going to affect. And so it's impossible in the vast majority of patients to assign parental origin. In some cases, like I showed one family, the father and the children all had the same phenotype. So the father was much milder. So they didn't have very strong autism, and probably that's what was compatible with having children and having a family and everything. But when we diagnosed the 3 children and we rephenotyped the father, we found that they shared a genetic cause. So there, the cause is obvious; it came from the father. And then in some cases where it's recessive, it's both parents contribute equally. The mother and the father contribute equally, and in that case, they have to be related, because how else would they have the same mutation? And then the chances of a child with autism, if the parents are related, is going to be 25%, i.e. 1 in 4 children. But it's important, there's a 4th subset, which are X-linked mutations. If it's an X-linked mutation that's causing the disease in the child, if it's a male child, it has to come from the mother, because the male inherits their X chromosome from the mother. If it's a female child, it could have come from the mother or the father. It's X-linked. I hope that answers the question.
Yes. Thank you so much for answering this question. We actually have other questions for most of the panelists. There's a question that was repeated too many times for Dr. Madiha. You've spoken about the importance of working with the children on improving their communication. So perhaps, doctor, can you share some strategies that parents can use when working with their children on improving communication? Dr. Maliha, can you hear me? Okay, perhaps we can move on to the next question. Dr. Ammar, one of the attendees is asking, how does the presentation of ASD differ by age? So as the individual with ASD become older, would their presentation be different?
Yes, for sure. With the early detection, the early intervention, with the effort of the family and the therapist, the presentation of autism for sure will improve, will progress positively with time, especially if the child has good potential. So the presentation, the repetitive movement will decrease with the time. The speech and language communication will improve. So, as mentioned by Dr. Madiha, the presentation in teenager, adolescent is a little bit different.
Yes.
Yeah, so the main issues in age, adolescence, and elder age is the specific interest, the poor maintaining relationships and friends, and with the rigidity, poor understanding others' emotions or feelings. So it's mainly rigidity and deficiency in theory of mind. Understand the emotions of other, sharing emotion with others. So the presentation will improve with the time. Is the symptoms, the playing abilities, the learning, the academic will improve with the time. And the main issues that in some cases will remain is the rigidity, the poor social communication, poor relationship. I hope I answered the question.
Thank you so much. Our next question is for all panelists to answer, really. There were many questions tackling the use of children's shows, perhaps also putting the children in nurseries. Do you think that could help with the symptoms of ASD?
Yes.
Doctor, go ahead, Doctor.
So I think, yeah, our initial advices for the family with the newly diagnosed autism to reduce the screens and to put it a zero if we can, and keep the screens for as prompt for when the child achieves some improvement. We can use these screens as a prompt for logic time. So reduce the screens, engage in nursery, daycare with the normal kids is also very important. The efforts of the parents also is very important. A lot of kids within 6 7 months of intervention reduce the TV screens, enroll in nursery with parent education program that we provide in HMC Al Maha Center, Early Bird, and other parent education can improve the picture of autism within logic time. Alhamdulillah. For sure, the autism is a long life disease. We cannot, unfortunately, in all cases, cover all issues that he has, but at least there is improvement. The improvement is positive, even it's slow. It's very important. As I mentioned always, if we remove or toilet train a child with autism, it's a good achievement. If the child hug his father when come from his work, is a good achievement. When the child has a better eye contact, social smile with his family, is achievement. So even the minimal improvement, slow progress in the child profile is very important for us and for the parents. It's not necessary to be normal rapidly or within 1 year, 2 years. The slow progress is important. That's why the enrollment in nursery in schools, and after that in the special needs school, which is يعني common in Qatar, Rinad, Al Hidayah, the other schools which can deal with the autistic children properly. We enhance, advise the parents to contact RUA team to get evaluation, recommendation to appropriate school placement for these children. Yes, thank you.
Thank you, Doctor. You mentioned the RUA team. Can you perhaps give more information about this team?
Yeah, so RUA team, it's a combination between Ministry of Education, okay, Special Education, and Ministry of Health, okay. It's a team, it's located in Medinat Khalifa, I think now. They get referrals from Healthy Center when the child need a medical certificate before engaging in school, or from the school when the child is 7, 8, and the school detected some difficulty in learning, make relationship. So they refer these children to RUA team. RUA team, they are a full team expert. They make a full assessment for everything in the child profile. And at the end, they can get a diagnosis and recommendation. What type of support the child need, what type of recommendation, behavior, speech, occupational, and they collaborate with Ministry of Education, Special Education, to choose a appropriate school for these children.
Thank you so much. I'm pretty sure this information will be really helpful because then healthcare providers can actually direct the patients and their families towards such services. Thank you so much. Dr. Zach, this is the end of the list of questions on my side. Do you have any questions on your side?
I think just in the interest of time, we have some further questions, but we can introduce those into next week's panel discussion. So next week's panel discussion will be ASD and co-occurring conditions. And this will take place next Wednesday from 1 till 2 p.m. So we look forward to welcoming all of our participants to next week's session. If we haven't been able to answer your question today, please hang on to that and we can bring it to next week's panel. I just want to say once again, thank you to our panelists, Dr. Khalid, Dr. Suna, Dr. Madiha, and Dr. Ammar. Thank you so much for giving up your time and sharing your insights with us. And we look forward to welcoming you back to the subsequent webinars over the next 4 weeks. Thank you so much, everybody, and thank you for joining us.
Thank you for having us.
Thank you.
Assalamu alaikum.
Alaikum salam.